Thank you very much, both of you, for wonderfully handling everything. So, even after post lunch session, I can see so many people are still here awake. So, thank you for being here. So, this is when I was preparing the slides day before yesterday. મારી વાઈફ હતી બાજુમાં મને કહે છે એના ઉપર બોલવાનું છે મેં કીધું કોમન મિસ્ટેક્સ ઇન ડાયાબિટીસ મેનેજમેન્ટ મને કે તારો ફેવરિટ ટોપિક મેં કીધું કેમ તને ભૂલો કાઢવાની બધાને મજા આવે ને So today it's not here to find out the fault of anyone, but let's see what mistakes we are making in our day-to-day management and how can we avoid them. So basically most of the part has been discussed. This will be a quick brief revision of what we have discussed earlier. Mistakes in diagnosis, because of that it's already majority of the time delayed. So let's see one example. Common day-to-day patient, 48-year female, present with the symptoms of URI. CBCCR we were ordered, they were normal. Random blood sugar was advised, it was 169. She was advised medicines for URI and sent back to home with the words that you take little less sugar, your sugar is little high. So patient went home, but patient took second opinion. Physician advised HbA1c. HbA1c was 7.8. So if you have missed the HbA1c testing in this patient, you must have missed the diagnosis, and it may take several years later on to re-diagnose this patient again. So you check HbA1c or fasting postprandial or OGTT in such type of cases rather than relying just single reading of random blood sugar. So common errors we are missing, ignoring IFG, IGT. We are not screening high-risk patients. We are relying only on single fasting sugar or single random sugar, not checking HbA1c, that too in a good lab with HPLC method. Because of that, diagnosis is delayed. We are missing early intervention and patient presence in the later stage with already established microvascular complication. Second is misclassification of diabetes. This is again revision. We are labeling almost all patients of diabetes, adult patients, as a type 2 diabetes, but they are not all type 2 diabetes. Many are LADA. So those typical phenotype who are lean diabetic, poorly controlled on multiple oral medications or any history of autoimmune disease, you have to consider this entity and check for C-peptide and antibodies for type 1 diabetes. Secondary diabetes, chronic pancreatitis related diabetes, it is again not uncommon. Many times you don't find the history of recurrent acute pain earlier or acute pancreatitis in this patient. They are just having silent chronic pancreatitis and pancreatitis related diabetes. So unless you check for ultrasound, you will miss the diagnosis. Off-label use of steroids, it's quite rampantly used still in our areas, and because of that many patients are having hypoglycemia because of steroid. So you have to ask detailed history about the use of steroid. કેમ કે એક બે વારમાં સિમ્પલ ક્વેશ્ચનમાં તો પેશન્ટ ડેફિનેટલી ડિનાય જ કરશે કે અમે કોઈ જ મેડિસિન નથી લેતા, but if you will ask repeatedly, then you will find that this patient is taking history of taking steroid from local medical store or from doctors since many years. Missing diagnosis of MODY, again this has been discussed. So always whenever you have a young patient with diabetes and there is family history of diabetes in 3 generations, you always look for MODY and ask for the genetic testing. It is now easily available and not that costly, so many will be able to afford. Mistakes in assessment of diabetes control. Let's see with one more example. 54-year-old male who comes in follow-up for diabetes medication. He is already on medicines and on treatment. His fasting sugar is 84, postprandial is very high, 275. So physician has advised to add acarbose before meal, before lunch, and continue with the other older medicines. So is it okay, or you need something else? So this is not the enough. You cannot decide on the basis of this single reading. So HbA1c was done. HbA1c was 6.5. So how it's possible? We had talked about HbA1c lies, but here that thing was not there. So how can PPBS is so high when HbA1c is 6.5? પેશન્ટને ડિટેલમાં પૂછ્યું તો કે મોર્નિંગમાં હું ગયો તો લેબમાં ઇટ વોઝ એ સ્મોલ ટાઉન. 9 વાગે અમારે લેબ ખુલે એટલે હું 9 વાગે ફાસ્ટિંગમાં બ્લડ આપ્યું. પછી લેબ ટેકનિશિયને કીધું કે હવે ઘરે જઈ બરાબર જમી અને પાછા 2 કલાક પછી આવજો. એટલે પછી 2 કલાક પછી હું જમીને ગયો. 11 વાગે પાછું બ્લડ આપ્યું. પછી પેશન્ટની હિસ્ટ્રી લીધી કે વોટ ઇઝ યોર રૂટીન. સો પેશન્ટ સેઝ આઈ હેવ બ્રેકફાસ્ટ ઇન ધ મોર્નિંગ એટ 7 o'clock, then I will take lunch at 11 o'clock. મેં કીધું શું લો બ્રેકફાસ્ટમાં? તો કે 1 ભાખરી મોડી ચા. લંચમાં તો કે 2 રોટલી ને શાક. અને આમાં મેં કીધું શું ખાધું હતું? તો કે 5 રોટલી ને દાળ ભાત પેટ ભરીને ગયો હતો. So that was the reason. So we don't ask this kind of questions and we start simply medicines or we change medicines. So unfortunately, still large number of people rely on just RBS. Many are just checking glucometer sugar at hospital and deciding the treatment on base of just these 2 parameters. Some are using fasting and PPBS, but we never ask for the history of food and timings. HbA1c, unfortunately, still many people are not doing, and some are doing, but we are not doing with the proper method, that is HPLC, that is the gold standard. So all the patients, even if blood sugar is well controlled, you have to check with HbA1c at every 3 to 6 months. SMBG, we discussed earlier, SMBG, even in those patients who are on insulin, people are not doing SMBG. And OHA, of course, hardly few people are doing SMBG, those patients who are on OHA. CGMS is hardly used by physicians for patients who are on oral medications, but again that is very useful, particularly those patients who are on sulfonylureas. Let's see what we make mistakes, those patients who are on insulin treatment in follow-up. Again same thing, patients insulin લેતું હોય પણ પેશન્ટ પાસે ગ્લુકોમીટર જ ના હોય. 2, 3, 4 વર્ષથી ઇન્સ્યુલિન લેતું હોય, ફોલોઅપમાં જાય ખાલી ફાસ્ટિંગ PPBS કરીને એ પ્રમાણે આપણે ડોઝ એના પ્લસ માઇનસ કરી દઈએ. બટ દેટ ઇઝ નોટ પોસિબલ. એ 2 રીડિંગથી યુ કેનોટ કંટ્રોલ ડાયાબિટીઝ. યુ મસ્ટ પ્રિસ્ક્રાઇબ glucometer along with insulin. Wherever you start insulin without monitoring, it's not possible with any type of insulin. ગમે એવું insulin વાપરો, it's not possible without monitoring to control diabetes. CGMS, again, those patients who are on insulin therapy, once in a while, at least those patients who can afford, હવે 4,500-5,000 રૂપિયાનું આવે છે, it's not that costly, પણ જે બી લોકો, everyone is not going to afford, I agree, but at least in some kind of patients, those who can afford, you should advise CGMS, not regularly, continuously, but once in a while, you will have the idea about time in range, glycemic variability, post-meal spikes, asymptomatic hypoglycemia burden. So unless you will do CGMS, you are not going to get this all answers, and that is very, very important because we know glycemic variability and time in range, they are directly proportional to the microvascular complications irrespective of your HbA1c level. So unfortunately, people still are not ready for adopting new technologies. So it's not that difficult, it's very easy. તમે નહીં કરો તો પેલા જે CGM વાળાના MR ને કહેશો એ આવીને મૂકી જશે, બધું સમજાવી જશે. Hardly it will take few minutes. Not starting insulin in time, already we had discussed this. Let's start with one example. 65-year-old female, diabetic for a long duration of time, 22 years, BMI 28.4, HbA1c 9.5, on multiple medications, glimepiride, metformin 2 plus 500 twice in a day, sitagliptin plus DAPA, pioglitazone 15 milligram. Patient is regular in medicine, following proper diet, doing 30 minutes walking daily. So આનાથી વધારે પેશન્ટ્સથી બહુ કંઈ થાય એવું નથી. So we cannot expect much. So what was done here and what can be done? So patient went to the physician for follow-up. Patient was advised to add acarbose, DAPA ને બદલે EMPA પર શિફ્ટ કર્યું અને glimepiride metformin 2 માંથી 3 times કર્યું. So what can we expect? 9.5 માંથી આટલા ચેન્જથી ક્યાં પહોંચી શકાય? Are we going to reach to around 7 or 7.5? It's not possible. Yeah, you can reach to 9, not lower than that. કેમ કે glimepiride 4 મિલીગ્રામમાંથી 6 આપો, 8 આપો, 10 આપો, it is hardly going to matter. So 3 મહિના પછી HbA1c was 9. પેશન્ટને પછી પાછું આપણે એવું કીધું કે લેટ્સ વેઇટ ફોર 3 months. જોઈએ આપણે 3 મહિના હજી તમે થોડુંક હજી આમ કરો. સો દેટ ઇઝ ધ most dangerous phrase we use in our day-to-day practice, let's wait for 3 months. So we can't wait at this stage, we have to start insulin therapy. So that is there are so many reasons earlier we discussed, not starting in insulin time. It may be from patient side, patient are not ready to start, ready to accept the injections. Physician inertia is also responsible. Maybe many are very busy practitioner, we don't have time to explain. એક પેશન્ટને ઇન્સ્યુલિન વાળું બધું સમજાવીએ તો બીજા 3 એના એટલા ટાઈમમાં જોવાઈ જતા હોય. Maybe lack of knowledge or confidence, fear of losing patient, lack of support staff. So there may be some reason behind not starting insulin therapy. હવે લોકોને ખબર નથી કે knowledge નથી એવું નથી માનતો. But other reasons are there. So we have to find out the way to give some time, or we can have some support staff who can explain everything and start insulin in time. So this patient was started on ultimately Glargine 10 units at bedtime, and a patient was asked to come at follow-up up to 3 months. What happened? 9 માંથી 8.4. તો હવે ઇન્સ્યુલિનમાં તો આવવું જોઈએ ને કંટ્રોલ, કેમ ના આવ્યું? So what was missing here? Monitoring. So there was no titration advice, there was no monitoring advice. Patient was just given the prescription of Glargine 10 units and asked to come in the follow-up 8.4. So we need to tell them, you check blood sugar at home with glucometer and you decide according to your fasting blood sugar. Every week you check blood sugar, go on increasing the dose if you are out of target. Your target is between 80 to 120. So finally we advised this and patient was asked to come in the follow-up, and this is the result after 3 months. 8.4 mati 7.8. So is it okay now, or no? We need around 7, at least below 7.5 considering patient's profile. So now what we can do? Fasting તો બરાબર જ આવે છે, પેશન્ટ માપે છે 80 થી 120 ની વચ્ચે જ આવે છે. So this patient can have post meal spikes, post lunch, post breakfast, post dinner. So we need insulin intensification at this stage. So what we can do, how we can decide other insulin or how we can change the insulin regimen, we have to ask them for 6-point SMBG, 3 pre-meals, 3 post-meal, then intensify insulin. There are several options for that. You can change over to twice daily premix insulin in this kind of patient, or you can give basal plus single bolus in the time where post-meal sugar is high. So let's see one example. After 6-point SMBG, fasting post breakfast, pre-lunch, post-lunch, pre-dinner 154 and post-dinner is 246. So what should be the treatment here? So most of sugars are fine. Only problem is post-dinner. Patient must be taking heavy dinner. So what we can do here, we can continue with the basal insulin and just add small bolus 4, 6, 8 units short-acting insulin before dinner, and that will take care of that part and your sugar will be normal. In case if both are high, for example, post breakfast is also high, 220, post dinner is also high, post lunch is reasonably okay. So in this kind of patient, you can change over to premix 30-70 preparation twice in a day. You can stop the basal insulin. So insulin selection is also very, very important. Using bolus insulin alone, ખાલી regular insulin patient ને ચાલતું હોય 1 વાર 2 વાર 3 વાર, એનાથી ક્યારેય control નથી આવવાનું, ગમે એવું patient હોય. So because there is no basal component, you are just giving short acting insulin, you are not going to control sugar whatever dose you are giving. Using premix plus basal, still this is very favorite prescription of many people. Patient 30-70 preparation લેતું હોય premix twice in a day, control નથી આવતું, તો what they are doing is પેલું continue રાખે અને add the basal insulin, add Glargine. So you just imagine premix માં 30-70, 30 is short acting, 70 is long acting, ઉપરથી તમે પાછું એને Glargine start કરો છો 10-15-20 unit. So almost 80% of your insulin is in the form of basal long acting insulin. Only hardly 15-20% will be in the form of short acting insulin. So this is the wrong regimen. You should not use this. Many are using premix 3 times in a day, 30-70. 2 time ચાલતું હોય, intensify કરવા માટે 2 માંથી 3 કરે before each meal. But again here also same thing will happen. Basal part વધી જશે, bolus will not be sufficient. So this is also not proper for most of the patients. ઘણાનું આનાથી આવી બી જાય. It's not like કે કોઈનું ના આવે, પણ it's not largely, it's not the right regimen. So what are the proper insulin regimen? If you are starting newly, start with basal, that is fine. If it's not controlled with basal, you can add bolus, either 1, 2 or 3. You can go on intensifying according to the requirement. Premix twice in a day, 30-70 preparation, that is also fine. Sometimes if premix 30-70 twice in a day is not working, you add short acting before lunch, that will also work in some patients. Or sometimes premix 50-50 may be working in some patients 3 times in a day, but again not in all patients. So that was about the proper insulin therapy. Other mistakes is regarding the assessment of complications. We don't do routinely urine albumin creatinine ratio. We don't do EGFR. આપણે ક્રિએટિનિન એડવાઇસ કરીએ પણ EGFR ક્યારેય નથી કહેતા. ફોર્ચ્યુનેટલી હવે ઘણા લેબવાળા આપવા માંડ્યા છે સામેથી, તમે ન લખો તો બી. પણ these are two are very very important parameters. આના બે પરથી જ આપણે ડિસાઇડ કરીએ છીએ. EGFR ઘટે છે તો we have to reduce the dose of certain medicines. મેટફોર્મિન ઘટાડવી પડે, સિટાગ્લિપિન ઘટાડવી પડે, dapagliflozin ક્યારે બંધ કરવી, we decide on the base of this. So if you are not doing EGFR, how you can decide that? Albumin creatinine ratio nahi karo to when you will know about the microvascular complications? Unfortunately, most of the people are not doing this. So we have to ask for urine albumin creatinine ratio at least once in a year in all the patients. કેટલી બધી medicines છે આપણી પાસે that we can use in the early stage of diabetic nephropathy. Whenever patient is having microalbuminuria, you start using AC inhibitors or ARBs to reduce that. We have SGLT2 inhibitor for proteinuria reduction, GLP-1 based therapy, we have Finrenon. હવે તમે ચેક જ નહીં કરો તો how you will use this? So use albumin creatinine ratio at least once in a year. Fundus examination, neuropathy assessment, that is also necessary. Macrovascular complication assessment, we all know. I am not going to into the detail. ECG બધા કરી લે છે, બાકીનું કાંઈ નથી કરતા. ECG કેમ કે મશીન બાજુમાં જ પડ્યું છે, જાઓ એક ECG કરાયો, પણ ECG માંથી શું ખબર પડશે? Nothing. You cannot assess macro ongoing chest pain હોય ને ECG કરાવો તો you will have some idea. બાકી complication assessment, cardiovascular assessment is not possible with ECG alone. So you need a battery of tests in high risk patients. Selection of OHAs, let's briefly see with this patient, diabetic patient, BMI 27, RFT LFT normal, 38-year-old male, HbA1c is 9. So this is a new patient with diabetes and HbA1c is 9. So still in this kind of patients, large number of people use metformin and sulfonylurea combination as a first line therapy. Definitely it is going to reduce your HbA1c, તમારું HbA1c control આવી જ જશે, but that is not the first line treatment. You can have other multiple options, metformin, SGLT2, metformin DPP4 or GLP based therapy, SGLT2 and DPP4 or GLP based, or you can use triple combination. Later on, if still require, acarbose, pioglitazone, and then comes sulfonylurea. Ultimately તો મોટાભાગના લોકોને આ જોશે જ, એના વગર ચાલશે નહીં, પણ it is not the first, second or third line choice. Fourth, fifth કે sixth માં you can use. So again, shortly, diabetic patients, CABG before 2 years, BMI of 28, ejection fraction is only 40, urine ACR 98, creatinine normal. This patient is on metformin 2 gram, HbA1c is 6.9 plus additional cardiac medicines. Do we need to change OHA? આમાં 6.9 HbA1c તો છે, આમાં શું ચેન્જ કરવાની જરૂર છે? Yes, we need not only SGLT, we need SGLT and semaglutide or tirzepatide for cardioprotection and mortality benefit also. So you stop medicine, start this too, and monitor sugar accordingly. So wrong drug for wrong patient, not using SGLT2 in CKD or heart failure, not using GLP-1 based therapy in patients with obesity and established cardiovascular disease, using pioglitazone in patients with edema and heart failure, using sulfonylurea in elderly, using sulfonylurea as a first line therapy. Statin, largely we are underutilizing in diabetic patients. Again, let's see one small example. Type 2 diabetic patient for 4 years, OHA, HbA1c well controlled, 6.9, BMI of 24, no other comorbid conditions or cardiovascular risk factors, and this is the lipid profile. LDL 94, triglyceride 145 and HDL 46. શું કરશું? LDL એ નોર્મલ છે, બીજા રિસ્ક ફેક્ટર નથી. સ્ટેટિન અપાય કે નહીં? Yes. So what ADA says, any patient with age more than 40, irrespective of their baseline LDL baseline normal hoy, to be any patient with age more than 40, you should use statin for cardioprotection. And these are of course other indication when patient is less than age 40 with multiple risk factors we have to use. So lifestyle modification we already discussed. I am not going into the detail about other part. So to summarize, we are often making mistakes in delay in diagnosis, classification, not proper in monitoring with SMBG, CGMS and HbA1c, therapeutic inertia in starting insulin late, not using proper medicines, ignoring cardiovascular risk and weak lifestyle counseling. Thank you very much.